I have a good friend who's a special forces operator in a previous life. And him and I often talk about the similarities between what he used to do and what I do on a daily basis, which is orthopedic surgery and more specifically limb reconstruction surgery. In these shared sessions, it became evident to me that we really do share a lot of similarities in the way that we approach difficult problems. And really at the core of this lies the access to proper and superior equipment, the access to intensive training, and also rehearsal of scenarios in a, let's call it a mock-up environment, which is essentially what we do in preoperative planning. And then lastly, we all have access to superior tactics. Now, in their world, it would be tactics like close quarters combat, or taking down a building, or indeed jumping from a perfectly good aeroplane. In our world, tactics really boil down to things like adequate fixation of fractures, proper management of soft tissue, distraction osteogenesis, and all these wonderful things we've been hearing about in the last few days. My name is Frans Berkels. I am a limb reconstruction surgeon based in Pretoria, South Africa, with a fair amount of experience in both the pediatric and adult limb reconstruction field. A lot of my work revolves around post-traumatic limb reconstruction, but I am also, dare I say, a reluctant foot and ankle surgeon that gets involved with difficult foot and ankle pathologies on a regular basis. So without further ado, we're going to spend the next 14 minutes or so talking about frame strategies and osteotomies as they specifically pertain to foot and ankle surgery. Now, a lot of what I say is available in this book chapter that I co-wrote with Mikhail Sanchikov and Alex Cherkashin recently, and we have really elucidated a approach to really demystify and in a way make foot and ankle frames more accessible. Let us first start with thinking of the uses of external fixation in foot and ankle surgery. So where are those specific conditions where external fixation may well be useful in foot and ankle surgery? Now, the first thing to decide is, what do we want to do with the foot? Do we want to simply stabilize it? Do we want to stretch soft tissues like in an Aquinas correction? Do we want to fuse joints? Do we want to cut bones and move them around? Or do we want to do a combination of these techniques? And really, this is what orthopedics in general is about, but also foot surgery in general. But more specifically, when we get into frame-based surgeries, we need to start thinking, what is it that we actually want to achieve in this specific instance? If you're into algorithms, this is an algorithm from this book chapter, which can really help you in defining what type of frame to build for a patient. So in essence, we're going to start with whether a correction is necessary. If it is necessary, we're going to go this route, which the next question is it going to be an acute correction or not? If it's an acute correction, we're going to default to an Ilizarov frame. Likewise, if there is no correction necessary and we really just want a holding frame, then your frame would be more of an Ilizarov type device. Now remember, the Ilizarov type device that I use here is not a brand name. It is really just the type of frame that Ilizarov came up with. And this can be built with a number of circular fixators on the market, including in these instances, the TrueLock device from Orthofix. Now, if we do not want an acute correction and we really just need to go for a gradual correction, the next question is it a complex deformity or a simple deformity? If it is a complex three-dimensional deformity that will need simultaneous gradual reduction, then of course we need to go for a hexapod fixator. If not, then we can also consider going back to a dynamic true lock or Ilizarov type fixator. Now, for a lot of us, there is quite a bit of interchange between these two devices, in that sometimes we would opt for the hexapod fixator anyway, because it is just sometimes simpler and quicker to construct, but it does come at the price of space. Real estate in the foot is quite limited, and we may need to find it very difficult to actually fit everything onto the patient's foot. Now, if we start looking at frame design specifically, I've devised this very simple FFF approach, which you can see summarized on the screen in front of you, because as primarily a trauma adult surgeon, I find foot frames extremely intimidating, and trying to think through what approach to use, I find that sometimes quite daunting, in fact. And really what I've tried to do with this approach is to try and give you a dummied down version of how to think your way through what the frame should look like for a specific patient. And it's the FFF approach revolving around fragments, focus areas of treatments, and fixation planes. And we'll go into these in a little bit more detail. So fragments, really, I find it very useful to think of the foot in terms of specific discrete fragments. Now, these are the main fragments you see in front of you, but these fragments would essentially change depending on what you're trying to achieve. If I were to do an equinus correction or an ankle fusion, I would define one fragment over there, and I would define a second fragment over there. And by seeing these two fragments, I can immediately see what I need to do with them in order to get the desired result. Now, I might decide that it is a midfoot correction that I need to do. Let's say a Charcot rocker bottom foot, where we might need to correct through the midfoot, which means that this will become one fragment, and this may well be the second fragment. I might be dealing with a much more complex situation, where I may have an ankle that needs to be corrected, and maybe a hindfoot that needs to be corrected, and a forefoot that needs to be corrected separately, and that would give me 3 fragments. In the majority of cases, it is useful to try and reduce, and it's even possible to try and reduce your problem, your clinical condition, into 2 fragments. And you could maybe really deal with a single area where you want this frame to do something in order to achieve your end result. So what I mean with that is, for example, in our rocker bottom foot deformity, I might be able to correct this hindfoot fragment acutely in relation to the tibia through the ankle joint, and then fixing that as a static single fragment before then gradually correcting the forefoot in relation to the hindfoot. And that would reduce a complex deformity into a relatively simple one containing 2 main fragments. The next concept is the concept of focus area or focus treatments. Now, really, the focus area is where do you want this frame to perform its job? And if you are going to fuse an ankle, that focus area is going to be the ankle joint. That's fairly simple. If you are going to do a midfoot correction, the focus area becomes the midfoot. The focus treatment is really what we alluded to earlier, is what do you want this frame to do at the focus area? In other words, do I want this frame to move to correct the deformity? Do I want this frame to compress to give us an arthrodesis, for example? Do I want to do an osteotomy and move that around? Or do I want to do soft tissue stretching? So it really bears relevance to, at this time, take a moment to just understand, firstly, what the focus area is, and secondly, what you want to achieve at this focus area. And typically, the focus area would also be located in between the fragments. So it actually becomes a logical flow of things. The next thing to consider is the fixation plane. In other words, how am I going to fix this fragment to the external support, to the ring? And I find it very useful to think of the longitudinal axis of that fragment and then have my ring orientated at 90 degrees, orthogonal to that. So if we look at the tibial axis, then that would be an orthogonal ring placed like that. If I look at the foot, remember that this foot has now been reduced into a single fragment, which I might want to move from procavartin to recavartin. And then it becomes logical to actually see this fragment as having a vertical axis. So the foot would have a vertical axis, the tibia would have a vertical axis, and my two rings would be orientated at 90 degrees to each of those axes. And in that way, the fixation planes help us to understand how the rings would be orientated most optimally to achieve the desired result. Right, so there's an example of an equinus correction or an arthrodesis frame for that matter, where we're going to use the two fragments, one on the top, one at the bottom. We're going to have a focus area, which is the ankle. We're going to have focus treatment, which is going to be a gradual correction. And the fixation planes are orientated as is shown there, which gives us this frame construct. Now, taking it one step further, maybe we would like to do a midfoot correction, which really gives us a fragment at the back and a fragment at the front. And it would be useful then to have our focus area in between. And our fixation planes would then be orthogonal to those fragments. And now it becomes logical to use a frame something like that. Now, generally, these frames are also linked to an extra ring at the top, which then makes it a mitre frame, which is quite a workhorse for a lot of foot and ankle surgeons in this field. Over here, we've basically reduced our hindfoot fragment into one by fixing it orthogonally between the heel and the tibia using what is called a butt frame construct. And then our moving part, our focus area is going to be the midfoot. Our fragment that's going to move around is the forefoot with a fixation plane that's orientated at 90 degrees to that. So you can see how logically going through this flow, you can start thinking up wonderful constructs to fix complex three-dimensional foot deformities. And really, this process has demystified this concept, at least in my mind, in a very helpful way. This is a double focus area frame where we want to do a correction through the ankle and through the midfoot. And for that, we create a mitre frame, as you can see there, with basically one fragment over there, the second fragment over there, which becomes the first fragment for the second correction, which happens in relation to that fragment. So one fragment, two fragment, number three fragment, focus areas number 1 and 2, fixation planes number 1, 2, and 3. And in that way, we've actually designed a mitre frame. So let's talk a little bit about osteotomies. I think, obviously, foot osteotomies are not as intuitive as they may seem, although all of us have done foot osteotomies quite extensively. Most of us have done chevron osteotomies, Ludlow or scarf osteotomies. We may have done things like calcaneal shift osteotomies, and I think all of us have done supramalleolar osteotomies to a certain extent. Now, those are all relatively simple, if you will excuse my common term. They are generally performed with oscillating saws, and they are done very commonly. Now, what we're talking about in this context is not those osteotomies. What we're talking about in this context is really an extrapolation of the corticotomy concept, where we're really breaking bone in a very biologically sound way to ensure that we can generate new bone, that we can create a regenerate. So as much as it is important in the femur or the tibia or the humerus or even the forearm to do that, it is also important to do it in the same way in the foot. And specifically, to try and preserve the soft tissue envelope and really not create an osteotomy where there's smoke coming out of the wound and, heat being generated and huge approaches and so forth. So the principles of corticotomies really translate into foot osteotomies for this purpose as well. And realistically, these happen in a few places. So the most common one that we would probably encounter, all of us, at some point, is the supramalleolar osteotomy. And generally, that can be done in two ways. So we could use the classic sort of corticotomy technique, if you will, where we do a osteotome-based corticotomy, which may or may not involve pre-drilling using a small drill bit. So the pre-drilled corticotomy technique is really what is known as the De Bastiani technique. It was devised or described by De Bastiani from Verona. And then the classic corticotomy, where we really only use an osteotome, was originally described by Lazarov. Now, both of those techniques are very valuable. The difficulty with the supramalleolar osteotomy corticotomy is that all of us tend to make this osteotomy too far proximal. And if you're dealing with an apex of the deformity very close to the ankle, and you do your osteotomy too far proximal, you will induce an osteotomy rule number 2. And that osteotomy rule number 2 may give you so much translation of the bone ends that it becomes a problem on the soft tissue or on the bone healing. So just bear in mind that corticotomy is often too far away from the joint and too far away from the apex of the deformity by accident. It's very easy to sneak it too far away. Now, the second type of osteotomy that we can use in the supramalleolar region is really a jiggly saw osteotomy. And what we do there, and I would encourage your table instructors to show you how to do that, but you basically make little soft tissue windows all around the ankle, and you carefully pass your jiggly saw essentially subperiosteal around both the tibia and the fibula, and then gradually cut through the bone at a specific level. The beauty of this is it gives you a very clean cut. It gives you a complete osteotomy. The downside is if you do happen to put that jiggly around one of the important longitudinal structures, then of course that gets cut and that can have disastrous consequences. So it's very important to do this accurately and properly. The other useful tip there is to use guidance of K-wires on either side of your intended osteotomy to make sure that the jiggly does not skive off and create an oblique or an osteotomy that moves away from your intended point. Right, so that takes care of the supramalleolar region. If we deal with calcaneal osteotomies, I find them done best with a broad osteotome without pre-drilling, but using the guidance of K-wires on either side. Now, it is certainly possible to do that with a jiggly saw. It is certainly possible to do that with a pre-drill technique. And it is indeed possible to do that with a well-cooled, sharp, oscillating saw as well. But that would require a massive soft tissue dissection, which may get you into trouble in terms of healing. So my workhorse in the calcaneus is an osteotome, basically classic, just banging the osteotome through, making sure that we don't hit important structures on the other side. That brings us to the next group of osteotomies, which are really the ones that would be done most commonly, and they reside in the midfoot region. So typically either through the navicular and the cuboid, or through the cuneiforms and the cuboid, or in some instances through the bases of the metatarsus. So generally, that would be the other group of osteotomies, and the position of those would depend a little bit on the pathology you're treating and where exactly the apex of the deformity is that you're trying to correct. Again, thinking of the osteotomy rules. Now, in terms of these osteotomies, I find it almost imperative to guide them with little guide wires, with little K wires that you insert on either side of where you intend that osteotomy to be. And then you can either use, again, like in the supramalleolar osteotomies, either the corticotomy technique or a technique using a jiggly saw. Now, a lot of people would default to a jiggly saw at this point, and you can actually get a very neat osteotomy using the jiggly. I just find that it is incredibly difficult to get the jiggly osteotomy complete without it jamming up on you, because a jiggly saw works at its best when the two legs of the saw is at 90 degrees to each other. Whereas once you bring those together and you start pulling in this direction, then it can jam up very easily. And there are little tips and tricks around that, but for practical purposes, that becomes a very difficult osteotomy to complete. Of course, also important to place the jiggly saw in such a way that it does not compromise the soft tissues around the bone. But you can do a very neat, very tidy, very elegant osteotomy in this way. Personally, I tend to identify my osteotomy line, and I then go and use small percutaneous approaches and osteotomes to really selectively do the osteotomy through all the individual bones as is required for this correction. So really, in a nutshell, osteotomies around the foot, not as daunting as they sometimes seem. Really important to make sure that you're in the right spot and remain in the right spot by using these guiding K-wires, one on either side of the osteotomy, and then you know that if you're going to start skiving off, the wire will sort of protect you to a certain extent. And then making sure that we do these with as much preservation of the biology as we can. So, I want you, when you start thinking of foot and ankle frames, think around these concepts that we have discussed and think of the equipment you have, how you're going to apply that using special tactics to try and execute your plan. Do not underestimate the value of training. You are at a training course, so it makes sense that you have an affinity for this. But also remember that preoperative planning and preoperative rehearsal is incredibly important when we're dealing especially with complex foot and ankle problems. With that, I thank you from a chilly Pretoria in South Africa, and I am sure you have enjoyed your time at the Hull Deformity course. It is certainly one of the most valuable courses in this field in the world today. With that, I greet you and enjoy the rest of your course.